Here we are tonight. It's Dr. Soloway. Great cases from the case files of Dr. Soloway. It is 7:14 p.m. Office hours just finished. And I first want to give a hello to my medical student friend in Argentina who thinks I deleted his messages and questions. This is not true. Unfortunately, we switched channels on YouTube, and some of the questions may have been deleted or lost. I apologize for that. So please stay with me and keep watching my lectures and sound bites. So I got inspired today. I saw two patients with severe hypermobility disorders. One came from Florida, one came from North Jersey, and drove 2 hours. I just got finished seeing these two patients, so I'm actually going to refer to my notes. My head is a little bit jumbled as to their cases, so I will take a peek at my notes here. And I promise I'll teach you a few things tonight. The first patient, her initials are MM. She's a 40-year-old female, and amongst her many problems, she had gastroparesis, diverticulosis, hiatal hernia, sternal chest wall pain. She was admittedly hypermobile. She admittedly had scoliosis. She had pain in her knees, elbows, shoulders, as well as throughout the entire spine, cervical, thoracic, and lumbar regions. Symptoms going on 7 or 8 months. It's her belief that after surgery for cholecystectomy, June 5th of 2018, she developed the pains that she later describes to be knees, elbows, shoulders, cervical, thoracic, and lumbar. About a month later, on July 10th of this year, 2018, or last year I should say, she noted a significant loss of appetite. In addition to the loss of appetite, she developed right lower quadrant pain. This pain is clearly different than the gallbladder pain. When she had gallbladder pain, it was the right upper quadrant. On or about August 9th, about 1 month later, is when the joint pain started. Interestingly, her joint pain involved stiffness. The stiffness occurred in the morning anywhere from 15 to 30 minutes, but the main feature of her pain is that it was related to use. The worst pain happened to be her knees, followed by her spinal pain, followed by the elbows. So, this patient also had redness of the palms. Not only did the patient have redness of the palms, the patient had easy bruisability, miosis, or they were nearsighted as they were wearing glasses for this, period. As I mentioned initially, the patient knew she was hypermobile. Okay, so now we're going to discuss hypermobility and some of my thoughts relating to the topic. Hypermobility is extremely common. I bet it makes up 25% of the patients that I see. It is almost exclusively missed by almost all other specialties. Hopefully it's not missed by rheumatologists or you guys watching this video right now. The hypermobility disorders are extremely heterogeneous, and frankly, for the most part, it really does not matter if the patient has Ehlers-Danlos, Marfan's, pseudoxanthoma elasticum, Stickler syndrome, osteogenesis imperfecta, or any of them, because from the rheumatologist standpoint, they're virtually all the same. Of course, Marfan's has the longer wingspan than height by 1.1. Marfan's would be associated with dislocated lens, very severe nearsightedness, and dilated aortic root, insufficiency of the aortic valve. Osteogenesis imperfecta will give blue sclera, multiple fractures at young ages. Pseudoxanthoma elasticum, the chicken neck skin, the classic retinal lesions, But generally speaking, when these people come to my office, the most common issues would be nearsightedness. Sorry for the pause, I am tired. Sprains, dislocations, hernias, joint pain usually with use, frequently knee pain from chondromalacia patelli, as the patella tracks laterally as the women walk upstairs or take long walks. Other common issues would be hernias or laxity of muscles, diverticulosis or laxity of the colon, pneumothorax or laxity of the lung. Basically, laxity of anything. So, laxity of the blood vessels leads to bruising. Laxity in the cornea leads to the blue discoloration seen behind and in the cornea. If you can think of an area and it's lax, it'll happen. If things are very lax, you'll get a cleft lip or a cleft palate, hence Stickler's syndrome. But in reality, we recognize these diseases, and in spite of everything I mentioned, the most exciting part or issue related to these conditions, which I find in a good 85-90% of the patients with hypermobility disorders, is dysautonomia. So dysautonomia can mimic Raynaud's. Patients get venous pooling. So I take these patients, I refer them to a cardiologist who specializes in testing of the autonomic nervous system. He can determine whether or not they are sympathetic or parasympathetic dominant. They'll be treated accordingly, occasionally with SSRIs, occasionally with tricyclic antidepressants. Generally, they do very well. They often present with sweating, hyperhidrosis, palmar erythema, again from venous pooling. I hope you get the idea. This is very common. It's associated with hypermobility. The people frequently have anxiety. They have panic. So a lot of anxiety and panic disorders are actually dysautonomia that is overlooked. A lot of fibromyalgia patients are mislabeled with fibromyalgia and have either dysautonomia with burning or sensations throughout their body that are abnormal, associated with the hypermobile joints, the scoliosis that can be seen. As you can imagine, if you take a spine and pull it taut, you can't have scoliosis, you'll have too much straightening. However, if you loosen it, you'll get a little sag, and that sag would be the scoliosis. And of course, back pain in these patients can also be from bulging discs. As we know, the disc will tend to slide around a little bit more because, again, it's not sealed tight, similar and akin to everything else I've said. I hope you found this information interesting, useful, and I hope you don't miss the next case of hypermobility that comes into your office. Have a great night, and shoot any questions my way. Thank you.